For this meeting, and it's very nice to meet you once again. So, without any further ado, I'd like to just share a small deck. Please confirm if the slides are visible.
Yes, sir.
Yeah, they are visible. Yes, Nidhi. Thanks for confirming, sir. Good evening, everyone, and on behalf of Abbott, it's my pleasure to welcome all our esteemed faculty members and participants who have joined us for another session of Bright Talks today. Today's focus is going to be on a roadmap to challenging peripheral artery diseases, and we shall see some of the interesting case presentations and talks by our panelists that I'm sure will give much deeper in understanding the management of peripheral artery disease. Before I move on, here is a necessary disclaimer. Without any further ado, I'd like to introduce and welcome our esteemed panel of physicians, Dr. Tarun Grover and Dr. Virendra, and thank them for acceptance to be a part of today's discussion. So they are well-known names of the physician fraternity, but I'll just take a couple of minutes to introduce them to our audience. Dr. Tarun, who's director and in charge of Peripheral Vascular Lab, Medanta, the Medicity Hospital. He has completed MD and FNBE from Gangaram Hospital, followed by MD Medicine from National Academy of Medicine. In his 25 years of career, he's successfully performed more than 10,000 vascular, endovascular, and 8,000 plus endovenous laser ablation procedures. He's also the Vice President of Vascular Access Society of India and one of the few physicians to perform vascular ultrasound duplex imaging in India. His vast body of work through cases, articles, clinical studies have found prominent space in various of national and international review. Welcome, sir. Dr. Virendra Keshuren, who's also our panelist for today's evening, is Senior Consultant Interventional Radiologist, Medanta Hospital, Gurugram. He completed his housemanship in orthopedics and forensic science from AIMS, Delhi, followed by residency in diagnosis from GMCH Nagpur. Later joined AIMS, Delhi to obtain his national fellowship in cardiovascular interventional radiology. He is known to have performed the largest number of endovascular therapeutic procedures in the country in a facility. He's a proctor on BCD, BMI, technology, EVAR and TEVAR procedures, and has several publications in his name in the journals, books of national and international repute. We welcome you, sir, for today's meeting. Thank you so much for joining. Our case presenters is again a very interesting ensemble of skilled operators today. Dr. Gaurav Chauhan, Associate Consultant Interventional Radiology, Medanta Hospital, Lucknow, and Dr. Abhishek Bansal, Body Cancer Institute. Thanks for joining us today. Dr. Rohit Agarwal, I just got to know that he would not be presenting because of certain reasons. So we will miss his presentation today. Here is the agenda of the meeting. We will have two case presentations by Dr. Gaurav, the talks by Dr. Tarun and Dr. Virendra. We will take any questions that may come to us by the audience and the participants towards the end of the session. I also would like to request Dr. Virendra to kindly engage our presenters in a discussion and initiate a dialogue after every case, once every case is presented. So over to you, sir. Now I shall request you to invite our presenters in a defined order. Thank you so much.
Yeah. So thank you, Nidhi, and thanks for the introduction. I think without wasting time, we'll go ahead with our first presenter. So just open the agenda. So Rohit is not presenting. So Gaurav, you go ahead.
Okay. Sir, is my presentation visible to all?
Yeah. Clear.
Okay. Good afternoon, everybody. I am Associate Consultant Interventional Radiology in Medanta Hospital, Lucknow. Today, we'll be discussing about carotid revascularization, and we'll discuss some cases of carotid stenting in this presentation. So, the concept of carotid artery was also known to the Hippocrates time, and the word carotid is derived from a Greek word kerotos, which means to sleep, to stun, or to stupefy someone. Because this fact was known to the people in the previous times that if we compress this artery, carotid artery, it will lead to the loss of consciousness. So the word carotid is derived from a Greek word kerotos. So moving forward, the concept of carotid endarterectomy was in place since 1951, when Carey et al. Performed resection and end-to-end anastomosis of this external carotid to the internal carotid artery in 1951. But it was only in 1953 when DeBakey performed first successful carotid endarterectomy with primary closure. So there was a constant feud between two surgeons named DeBakey and Cooley. So DeBakey claimed that he was the first one to perform the carotid endarterectomy, and the Cooley also claimed that he was the first. But it was only 19 years later, after which the DeBakey published his first case for carotid endarterectomy. First successful carotid artery stenting was performed by Klaus Matthias in 1977. He was German professor of neuroradiology. So these were the images of first successful carotid artery stenting. First patient with carotid angioplasty was patient of atherosclerosis. We can see in our screen that this is a stenosis due to atherosclerosis, and the carotid angioplasty was performed, and this was the result. And first accidental carotid artery stenting was had to be done in a patient in which angioplasty was performed, but the patient after angioplasty patient had a long dissection. We can see a flap of dissection in this. So on emergent basis, the carotid stent has to be placed in this patient. It was in 1989. With growing times, the concept of digital embolic protection device came into place in the market, and the concept of umbrella-like filter was also known to Klaus Matthias, who performed first carotid angioplasty, but there was no product available in the market. Then came the concept of digital balloon protection device, filters, and proximal balloon protection device like MoMA device and Go device, which are proximal protection device. So these are the few embolic protection device. So carotid artery stenosis is usually graded by either North American stenosis carotid endarterectomy trial classification or ECST. So NASCAT usually under mention the extent of stenosis as compared to ECST trial, but NASCAT is usually more reliable as it do not mention the plaque burden. It usually mentions the lumen burden. It compares the narrowest part of the carotid artery to the natural normal luminal caliber, which is distal to the stenosis, as compared to the ECST trial, which usually take account of the carotid plaque. So these are how we measure stenosis in NASCAT and ECST. NASCAT used to mention the stenosis segment. So starting with our case, this guy is a 57-year-old male, known hypertensive. He had multiple episodes of transient ischemic attacks, and Doppler showed ulcerated plaque. So this was the CT angio, and we can see here, this is the small tiny origin of the left ICA, and this is the common carotid artery. So this was the angiogram run, and we can see small ulcer in the plaque at this carotid bulb, and so we were able to negotiate our wire across the stenosis, and we placed it distal, and we have parked our embolic protection device, which is EmboShield NAV6 in the distal ICA, and after that we did a balloon angioplasty with 3 mm balloon, and this was the end result after balloon angioplasty. After balloon angioplasty, we placed a stent across the stenosis. So this is the AP view, this is the lateral view, and in this we can see stent being placed across the stenosis. So this image shows implanted stent, and this was the post ballooning of the stent. So this image, and this was the run after the angioplasty, and we can see stasis in the ulcer which was there in the plaque, and this was the intracranial carotid angiogram run. So it was a perfect case, good presentation type case where we were able to place the embolic protection device. We did pre-angioplasty, we placed the stent, and then we did post-angioplasty. So everything goes it place in place. So coming with another case where we have to avoid the use of filter. Cause I will let you know in a minute after showcasing this images of this case. So this was a guy, 60-year-old male, multiple episodes of TIA, and this was the CT scan images. We can see multiple hypotension in left periventricular area and along the left temporal lobe. So this was the CT angio image. We can see a tiny origin of the left ICA, and this was the CT angiogram reconstructed, and we can see a very tight stenosis at the origin of ICA, very tight stenosis. And these were the MIP images and 3D recon images. So we took the patient to the cath lab, and these were the arteriogram run, and we can see a very tight stenosis in the second image at the origin of this ICA. So we measured the dimension of the distal ICA. It was approximately 2.5 to 3 mm. So the embolic protection device which was available with us was not described for this dimension. So it was only for the vessels which have diameter 4 to 7 mm. So we discussed this with the family, and we explained the risk benefit ratio of not placing the embolic protection device, and the family gave us a green signal. So we went ahead with the plasty and stenting without embolic protection device. So it was, the risk benefit ratio was very well explained to the referring physician and the family. And also there was a calcified plaque. So we negotiated our wire, and then we did a tiny angioplasty with 3 mm balloon, and this was the result. We achieved something like 30 to 40% recannulation of the artery. Then we placed the stent across the stenosis. So after all, we have achieved 4 to 5 mm of diameter. Usually, if the diameter after stent placement is less than 5 mm, then post angioplasty is post stenting angioplasty is recommended. But we have to differentiate it with case to case basis, because there was no embolic protection device. So we have to give away for the post angioplasty ballooning, because it may lead to distal emboli shower. So this was the case which we did without embolic protection device, and the patient did fell. The MRI was done next day, which did not show any evidence of any stroke or ischemic areas in the brain parenchyma. So this is one of the most difficult case, almost topsy-turvy, or we can also call it a nightmare. It was 39-year-old young male who was rushed to the emergency, and he had a history of recent onset acute watershed infarcts. MRI with MRNG was done in our department, and these were the NCCT images. We can see multiple watershed infarct along right AC and MCA territory. And these are the diffusion weighted images. We can see multiple acute infarct in right AC MC territory, almost watershed territory. So these are the MR angio images. We can see long segment narrowing of the right ICA, almost looking like dissection because it was irregular in lumen. And one additional finding which is also visible is focal dilatation of the left distal cervical ICA. So it was dissecting aneurysm. This dissecting aneurysm we can also see in this axial MR images, in which we can see flow void, and in the right ICA we can see a dissection flap, the false lumen, and the true lumen, which is very narrow. So these are all the MR angio images. So this patient was referred from the neurology team. So we decided plan for emergent carotid artery stenting. So the patient was taken in the DSA lab. This was the run from left ICA, which showed incidental dissecting aneurysm in left distal cervical ICA. And then we hooked the right carotid artery, and this is the run from the right carotid artery. We can see a long segment dissection narrowing in the right cervical ICA, reaching up to the petrous part. So we were able to negotiate our wire across the true lumen, and so we So it looked like the dissection flap has started from this distal cervical ICA part. So the plan was to do the balloon angioplasty along the dissected segment and place a stent along the supposed part of origin of dissection. So the supposed part was the proximal most narrowing. So we did a balloon angioplasty across the narrow part of the carotid artery, and so this was the ballooning. We can see the ballooning was done along whole of the part, and this was a post ballooning run. So we have not achieved something. So it turned out a nightmare for us that even after angioplasty for the long segment, there was no significant relief of the narrowing. So we placed our first stent in the initial part of the stenting where we thought the plaque must have started, dissection must have started. So we placed a 680 Abbott stent along the proximal most part, 6840. So this was the run after placement of the first stent, and after that we can still see that the narrowing has not relieved. So we waited for some time and took another run, and even after that we can see dissection is still there. So dissection flap is usually it has spread along the length of the IC. It is not just a focal point of the dissection. So then we planned for stenting along the distal most part. So the plan was to place two balloon mounted stent along the distal most part of, because the long stents were not available in low profile diameters. So the plan was to place two overlapping short stents, 3 mm and 4 mm, along the distal most part of the dissection, which is still visible. So we placed two stents, 3 mm, 4 mm, across the distal most part of the ICA, and these were the angiographic runs. After placing three stents, we have reconstructed almost 100% normal lumen caliber, and the patient was discharged after admission in ICU for 2 to 3 days. And the patient came to meet us last month. So these were the images of patient and his wife. He is doing fine, and he has improved significantly after the procedure, and he has regained his power in right hand almost 4/5, and he has resumed his routine. He is going to work. So this was the three cases of carotid artery stenting. One with almost all the things together. With we have EPD, we did pre-post plasty, and another one without the embolic protection device with explanation of the risk benefit to family and the concerned physician. And the third one was emergent carotid angioplasty. So with this, I would like to end my slide with the note, with the quote of Charles Daughter. The vascular catheter can be more than a tool for passive means for diagnostic observation. If used with imagination, it can become an important surgical instrument. And in this image, we can see this gentleman is Claus Matthias, who did first carotid angioplasty. He is Andrew Grundzig, who did first coronary angioplasty. And this gentleman with the cunning smile is Charles Daughter, the father of intervention radiology. Thank you very much, sir.
Yeah, lot of great cases. Through your presentation, you have shown the simple way of dealing with endovascular dealing of carotid lesion. The cold cases, the emergent one. I think the third one was really kind of difficult and well managed, I would say. And role of on-shelf coronary stents, drug-eluting ones, whenever required.
Yes.
They're very helpful, I would say, and you guys managed it very well. So, Gaurav, what is your take on CA versus CAS? How would you refer cases for CAS? CA, I would say.
So it is an ongoing debate, and the doctors from both the modalities try to prove that their modality is best. But I think both the modalities are on separate ship, and they are going forward in future with all the indication and contraindication in place. So one modality cannot replace the another modality, and now they have also come with indications for CEA alone or CAS alone. So if there is a difficult anatomy and calcified burden is more, if the patient is old enough, so we should think about it and decide with our vascular surgeon. So which case should we take and which case we should be referring to the our vascular surgeon colleagues. So it's not about a fight between both the modalities. Both are important, and sometimes we have to go for a hybrid approach also. So so that's it.
Yeah, yeah. I think very your words for the conclusion in a nutshell is great. I think so. Actually, there is no competition, and every modality has its own indication, contraindication, and I completely agree. So each way of treating a carotid artery stenosis is very important, and the most important part is one should know when a certain modality should not be done. I mean, you should not push the limits
Yes, sir.
because can be done and can be easily done. There's a difference in that. So we should all know.
We should also know the difference between can be done or should be done. So there's a
Yeah, yeah,
fine
I
line
agree. I agree.
which
I,
we should respect.
I agree. So yeah, there should be a limit or a threshold for trying an endovascular. If the anatomy is difficult, if there is a circumferential calcification, definitely surgery becomes much easier. And as you said, if the patient has a lot of comorbidities, skin sight is not great. If it is secondary to radiation, there are a list of indications, contraindications. But well managed, and I think you have covered very well in your 10-12 minutes talk. So I think we can proceed with the next talk. I think Abhishek would be presenting on endovascular management of groin complications and access. So moving to you, Abhishek.
Thank you, sir. Can I share my content? So after some fantabulous cases by Gaurav sir, I have kept it simple. I'll be showing briefly. Is my screen visible?
Yes, sir.
Yes, sir, go ahead.
Yeah, Abhishek.
Okay, sir. Okay. So I kept it simple and I will talk about basics of groin management and vessel closure devices. We know the traditional way of taking a scissors or an artery, putting it on a femoral head on a fluoroscope to target the mid-head region. And this data by the UC San Diego that say that below the bifurcation of common femoral artery, the femoral head occurs almost 99% of the times below the bifurcation, at or below the bifurcation. What are the common access site landmarks? We know that the inguinal ligament actually runs above the inferior border of inferior epigastric artery. So, if this is the inguinal ligament, and this is the how the inferior epigastric artery comes up, and if any stick that is above the inferior border of inferior epigastric artery, that's considered a high stick and a high risk procedure. So a better landmark would be the takeoff the inferior epigastric artery as compared as vis-a-vis the inguinal ligament. This is how again this diagram shows how the inferior epigastric artery comes out from the external iliac artery, and below this should be the puncture of the common femoral artery. Again, landmarks talk about how we see this is the femoral head and how the femoral artery, common femoral artery, is punctured at the place where the common femoral head is. And so basically, common femoral artery is the external iliac artery below the inguinal ligament. Actually, sorry for this. And the external iliac artery further dives into the abdominal cavity. And therefore, wherever the puncture is above the femoral head, it would be difficult to compress or to close with a device. And femoral head provides a bony structure for manual compression versus any soft tissue, and you actually press against the bone for achieving the hemostasis. So this is again the iliac rim, how it is seen, and again puncture about. So this is one example. So in terms of coming on to the ideal stick, so we know that this is the inferior epigastric artery, this is the external iliac artery, and this is the sheath. So, but again, in terms of puncture, if you want to take it, you will see that this is the bifurcation of the profunda and the SFA, And the ideal stick, if you would see in this particular patient, would be slightly below the head of the femur. That is why it should be somewhere here. So again, there's a lot of variation in terms of where the a patient's anatomy is, and there's no fixed thing in terms of how the puncture would be. And it's very important to actually do two angiogram views, the RAO and the left anterior obliques, because it helps you identify the proper inferior epigastric artery origin, because many times it may be overlapping on one particular section, and it is important to actually know the bifurcation. That is why it is very important, especially before deploying a vessel closure device. You should be very sure that we are below the inferior epigastric artery puncture. In terms of complications that we commonly know, one of the dreaded complications is the retroperitoneal hematoma, and a lot of papers have been there. And the most common papers that talk about the risk factors are in terms of patients who have body surface area less than 1.7 and a high femoral stick in female patients, and any arteriotomy above the inferior border of inferior epigastric artery was associated with almost 100% retroperitoneal hematoma hemorrhages. And again, lots of people talk about sticks above inferior epigastric artery, female gender, anticoagulants, and again in terms of is the one particular use of angiocelia. I have to check with why this paper talks about that. So again, see if you would take the RAO view of 40 degrees. So this will be the ideal puncture point where it is above the bifurcation and below the origin of inferior epigastric artery. Retroperitoneal hematoma prevention is that we can identify the patients at risk and always do a careful femoral puncture. A careful puncture would be, you can use an ultrasound guidance where we would want to do a single wall puncture rather than a double wall puncture. In terms of recognition, it is very important that we recognize this complication. Otherwise, it can be a dreaded complication for the patient and even for the clinical team. So, definitely fall in BP, tachycardia, anemia would be something that will come on later on. But yes, tachycardia followed by BP, hypertension would be the first symptoms that the patient would have. The other signs, tenderness, swelling, pain would be the symptoms that the patient would be having.
Hello.
Again, in terms of appearance of symptoms, so one article talks about generally varies from 2 to 2.6 hours. That is when the symptoms start happening, and that is when these complications kind of recognized. So basically, normally if we have seen that, if we know that, rather we identify that it's a high femoral puncture. So thing is, the patient is already on antiplatelet, so leave the sheath in place until the anticoagulant or antiplatelet therapy has cleared. And instead of, we should treat these patients manual compression independent of whatever closure device we use. And definitely, as we have seen previously, the danger time is from 2 to 2.6 hours. So we should monitor these patients closely for the first 4 hours post procedure. And if any hematoma is clinically suspected, we should immediately start the resuscitation in terms of IV fluids, colloids, and even blood products as deemed fit. Even if the diagnosis is not confirmed by CT scan, and whenever we are doubtful about this, next thing should be go for a CT scan or a CT angio as well. So methods of achieving hemostasis, the traditional one is a manual compression. We generally give for 20 minutes and we make the patient immobile for the next 8 hours. 8 hours right lower limb or left lower limb immobilization, and utilize a lot of cath lab staff time and even the table time if you're doing the compression on the table itself. A lot of these patients do complain, rather you can imagine any of us lying straight for the next 8 hours is a very difficult job to do it. So definitely staff and patient unhappiness also increases. We have a sealant or a collagen based closure systems that actually deposit material which have coagulation inducing properties. To ensure clot stability, a flat time and a leg restriction is still required, though it may vary, and is traditionally less than the normal 8 hours that we suggest. But however, there are a lot of restrictions in terms of if it is a large arteriotomy, especially for a big endovascular procedure, then it's a problem. If the patient is on anticoagulation drugs, again, we have to check for the ACT level that's there in the cath lab, the blood pressure, and depending on various hospital protocols. In terms of mechanical closure, basically C3 is a method that that is like close, challenge and confirm on the table. And it is again in terms of a permanent surgical repair with a clip or a suture. And there's no clot required for arteriotomy and nothing plugs the tissue tract. So no blood, no body clot, so ACT and BP doesn't matter. The benefits of mechanical closure are it is a closed and challenged and confirmed on the table itself. There is no doubt about it. And the patient can bend leg, lift head and cuff also. Patient can themselves move to a stretcher. So basically, no flat time, no leg restrictions. Patients are more satisfied. We have seen a lot of old aged patients who would have urinary retention post angiography, and when we make them supine with a leg immobility, they're not able to even pass urine. So many of these patients would even require Foley's catheterization. So you can avoid this totally by this, and therefore increase. This will lead to happy patients and happy staff as well. So this is where from mechanical closure we have a suture mediated system for vessel closure, and it has a lot of broad indications, and actually parallels the surgical gold standards in terms of lower blood transfusions, infections, mortality, length of hospitalization, and actually promotes vessel healing. So there are no re-access restrictions. Like we are doing a lot of oncology workups like TARE Y90 treatments. So we don't have any re-access restrictions when we want to go in again for this patient again. There's negligible inflammatory response, and actually gives a in-lab confidence that you can actually ask the patient to immediately cuff after the once we have deployed this device mechanism, and it can be challenged on the table itself. Briefly talking about the ProGuide system, it can be used for sheets from 5 to 21 F with a maximum outer diameter of 26 F, 26 French. And these are basic device components. We all know what this. In the interest of time, I'll skip this. Again, the various methods of suture deployment, the steps 1, 2, 3, 4. Again, I think all of us have done this, so I'll just skip this and how the suture is eventually managed and achieves the hemostasis. So again, the 4 steps are important is that we have to prepare the device, first of all, flush it and advance the system over a guide wire, and then remove the guide wire once the when the ProGuide sheet is in situ. And once we actually see the spurt of blood, the arterial blood, then we just deploy the step 1 and then pull it back, step 2, 3, and then cut it, and then the later step 4 to remove the suture, to cut it, and then eventually to tighten the knot, we use the other handle and then do it. This is how we do it, suture management. I'm skipping all this and doing quickly so that I think this is just a theoretical basics part of it, how to do it. And this is how again the knot is locked and the suture is further trimmed. We can challenge the hemostasis on table and ask the patient to cough and do it. I'll quickly skip on to a video that we did this patient last evening only, and we'll just share the screen. So this is a video. This is a pre-op embolization actually, and this patient has a multiple myeloma in the right femur, and this is how we got to know that he's being planned for a surgery today itself. So late night evening, got this call that you have to do a pre-op embolization, and the patient's coagulation parameters was also not optimized. So we had took a left femoral axis to go on for the right embolization for the right side multiple myeloma, and because the patient's surgery was scheduled this early morning, we didn't have the time to actually do a manual compression for the patient and then risk for a hematoma, and that would have precluded further surgery as well. So again, I'll just this is simple steps how we do it. Taken out your sheet uh, over the wire. We're putting a ProGlide. Sorry for the video. Some network issues. So again, I think these are simple steps. What I've already shown you, and this is how we do it. But again, the importance is that how we are able to make the patient fit for patients. In otherwise, it would be difficult to achieve hemostasis. So these are the patients in whom we can use this device and do it further. Uh, So I think this is all about from my side, and just kept it simple in terms of what a ProGlide device is, how a malcompression is, what are the advantages of a ProGlide device, and how we do it. So this is again just at the end of immediately post the suture. Whenever the moment we tightened the suture, so it had fantastic results, and yeah, that's all from my side, sir.
Okay, great, Abhishek. I think you have covered all the importance of closure device, and through your case, you have again shown how important it is to decide when to use a closure device. And as the time is progressing, I would say most of interventionists are shifting towards use of a closure device, and the advantages you have already enumerated. The most important is basically uh, saving manual time, saving lab time, and a lot of patients, as you told, are posted for some surgeries, are on anticoagulation, dual antiplatelets. So it's very helpful because we all know a procedure, a well done procedure, and the patient can be lost if it bleeds through the groin. So it is equally important. Your access and closure is as important as it's your procedure. So I think again, okay, Abhishek, just one question. So most important thing uh, for success of a ProGlide, how would you rate it? So what is the most important thing for ProGlide to be successful? And, as Rohit is not presenting, you can start your talk, and then I'll go with mine.
Yeah, so I was given this topic that what's hybrid approach for critical limb ischemia, and how do we do these hybrid approaches? So basically, by hybrid we means we are combining the both the surgical intervention as well as the endovascular intervention, and the benefit is passed on to the patient. And most important is to understand that multi-level disease should be treated in one go for CLI. Some people might debate against it, but I would rather say that once you go through this presentation, you will agree with me that it's always worthwhile and more logistic to treat these lesions in one go. Okay, now the rationale for doing a hybrid revascularization is because we know critical limb ischemia mostly it manifests when there is an extensive multi-level disease. Most of the time, you won't have critical limb ischemia when only one level of disease is there, whether it's iliac or femoropopliteal segment or infopopliteal. So usually it's a multi-segmental disease, so which requires sometimes they are conducive to endovascular intervention, but sometimes I'll share some cases when you will see that doing some sort of a surgical intervention will complement the endovascular procedure. And these patients, they have multiple comorbidities and they are high risk for complete open surgical procedures. And hybrid interventions offers the advantage of both a well-established patency of open vascular surgery and less invasive endovascular intervention. And now, slowly and slowly, everybody in most of the tertiary care hospitals, they are having hybrid operating suites or they are having advanced C-arms in their operation theaters. So where these procedures are now easily feasible, and one single anesthesia is used for this patient, and significant cost saving is also there. So here you can see that in this patient, we discussed this patient. This patient had an iliac disease as well as a popliteal. So what we have done is we had to combine surgical thrombectomy along with the iliac endovascular management. And so once you get used to a hybrid procedure and you have a team where you have either the team has surgeons who are equally good doing endovascular interventions, or you can have a combination of IR and surgeons like we have in our team. So, you can offer the best to the patient. by having a synergy between the IR and the surgeons. So several revascularization permutation exist for hybrid procedure, and in broad terms, they can be separated into either you can do a surgical bypass, thromboendarterectomy, combination of a catheter-based intervention to improve both inflow and outflow, because sometimes that's a major challenge sometimes. And these are some of the images. So, all of you who have started doing all these complex total occlusions, you will see that sometimes these patients, they do have significant thrombus load. So though there are some endovascular options available in the form of angiochairs, you can lyse them before, you can do penumbra. And so these are some of the images of previous time when these mechanical thrombectomy devices were not available, or these patients were not fit enough to undergo a mechanical thrombectomy, because sometimes the associated hemolysis and all those things usually is a challenge, and you don't want to give a lytic therapy in these patients. So a simple small groin incision under local anesthesia, you clear the clots. If there is any residual lesion, you stent it, and then you can always close your femoral artery with a patch. And this is a very important thing to understand, that as we know that circumferential calcification is a contraindication for carotid stent as well. So similarly, a common femoral artery is a territory wherever, again, difference whether we should do it or we can do it. We can do it. We have also done a lot of supera stents in common femoral arteries, but those were a limited group of patients where surgical options were not available, or the overall long-term mortality was not that long that it required some sort of a surgical intervention. On a case basis, you can decide whether you want to offer a hybrid procedure or you want to do an endovascular. But these sort of plaques, if surgically removed, definitely they will improve the patency, long-term patency for the patient. And so these are the hybrid revascularization which we do. You can see Dr. Viren and I both in the hybrid lab. So you can see on the fluoro monitor you have the open groin, and once you have the open groin, because sometimes we see that the reformation of the superficial femoral artery is retrograde from the profunda, and there is a total occlusion of the common femoral. So if you try to endovascularize these patients or do purely endovascular, and if you don't enter the true lumen into the SFA, and if you go into a dissection plane into the superficial femoral artery and then you connect healthy to healthy, then you would end up sacrificing the profunda. So saving profunda is very important. So now with the acceptance of endovascular interventions for inflow procedure, several authors have gone to evaluate their experience, and share that ultimately the crux is that what they have shown is that if you combine, then you can almost come to the similar patency levels which were reported for open surgery procedures, and significantly you can bring down the mortality and morbidity for these patients. And so why not to pass on the advantage to a patient? So here you can see some of the vessels opened up, and these infant feeding tubes are into distal lumen. So sometimes you can see that if you see the picture on the extreme right, you can see some soft thrombus lying into the common femoral artery, and you can see the dermo wire coming out from the uh, cranial end of the femoral artery. So you have your wire out, you can clear the femoral artery, do an endarterectomy, put a patch, and then from the brachial root or the contralateral root, whatever you have chosen, and then you can stent it, and you have created an inflow and outflow both. And so these are some another cases where you can see. Now here you see that total external iliac is totally diseased. You don't see the common femoral even on a prolonged DSA. You don't see any reformation of profunda. So in such cases, what we do is we surgically explore the common femoral, because sometimes duplex you can see some faint refilling, retrograde refilling of profunda. So you surgically open them and diaphragmize the area, and if you feel that you get a reasonably good back bleed which can sustain the inflow, because if you don't create an outflow and you get an inflow, then everything will get thrombosed. So if you can create a inflow, and there you can see we have been able to create some flow in the SFA also, and then these patients usually are the ones who have critical ischemia. They have a
ठीक है
non-healing
बनवा दो
ulcer or an impending amputation. So if you are reasonably able to maintain a good flow in these vessels for a few months, usually the ulcer heals, and then over if the long-term
नहीं
patency, if
लेवल
it's
तो
not good,
चलेगी
also at least
लेवल
collaterals
तो
will
चलने
take
दो
over, and then you can
लेवल
start with
हटा दो
best
ना
medical therapy.
for 1 day, for
And
1 monthly.
more and
One
more
month.
thrombectomies, especially during COVID period,
For
were
pneumodeafin,
was done fluoroscopic guided because these
Pneumodeafin.
patients they presented
दो
late,
दे उससे
and
चला लो
usually we were doing
बाकी क्या
most of the
pneumodeafin 4 times
thrombectomies
चलेगी?
for acute limb ischemia, especially
फोर
for a
टाइम चला दो
thrombotic or an embolic
दो
occlusion
हफ्ते के चला
without
दो 15 दिन
fluoroscopic guidance. But here, because these patients they presented late, so we wanted to be absolutely
दोनों 5 दिन
sure
लिखा है
that
बस,
post
सिर्फ
thrombectomy
5
we
दिन.
have got I would say
दर्द है
total clearance of the thrombus. There is no residual thrombus left behind. And in case if there are areas which look diseased, they need to be stented, then that can be done. So this is our lab, and you can see hybrid vascular surgical techniques open a world of opportunity for these vascular specialists. So here are some things. You want to combine surgery, endarterectomy, stenting, bypass, everything can be done here. And so it's something I would say common sense. You can't buy it. So it's absolutely indicated. If you think you can pass on the benefit to your patient by opting for a hybrid procedure, you must do a hybrid approach. And quickly, this was the patient which I showed the picture in the beginning. This patient had an iliac lesion, and you can see there is a thrombotic occlusion of the popliteal. So these, you can manage with the penumbra also, and you can lyse also. But if you have and you feel that patient is fit enough to undergo surgery, so because sometimes the popliteal area is a very, I would say, calcified and a very thick, very hard thrombus, which usually sometimes doesn't resolve, and there is always a challenge of distal trash as well. So here an anti-gate puncture with the popliteal exploration was done. So popliteal thrombectomy was done, and a patch plasty was done, and this is the final completion angiogram. And here you can see the anti-gate puncture was closed with a ProGlide, and here you can see the pulsating popliteal with the vein patch. So what you can do is you can close the vessel percutaneously. The femoral approach, you have taken a shot, and in case there is a diseased post-patch, you can either place a stent or you can do a drug-eluting balloon for these lesions. Some other cases of hybrid revascularization, I'll quickly go through these. And we have, because we have a very active coronary artery bypass service, and this patient underwent an hybrid SFA with TB and stenting after a CABG. So I think it's natural for us, for any interventionist to explore as they evolve newer and newer avenues. So just a descriptive case to end the lecture. So you can see this patient has got an iliac diseased, external iliac diseased on the right side. The left iliac is also diseased, and there is a reformation. So now this patient has a critical ischemia. He has an SFA disease also on the right side. So now if you can do just an external iliac stenting, correct one level. A lot of people they say if you correct one level, then the disease patient they do better. But since if you have the facilities, so what we do is we have taken an open right groin access and a brachial access. And usually, what we do is if we have these long CTOs, we prefer superas in the external iliac because they conform better to the flexibility of the hip joint. So two superas on either side and two balloon expandable stents or self-expanding stents are usually placed in a kissing manner. So you have reconstructed your aortoiliac segment, and in the same sitting, because groin was exposed, SFA was diseased, a long segment SFA was diseased. So what you see here is an femoropopliteal bypass using a prosthetic graft. So this is the proximal anastomosis. You see nice filling of profunda, and this is the distal anastomosis, which you see there is a nice filling of the distal popliteal by doing a surgical bypass. So what you have done is with a two small incisions, you have recreated the aortoiliac segment and done a fempop also in one sitting. And these sort of an calcified plaques, I'm sure you don't want to stent these vessels and leave all this muck inside. It's always worthwhile. So this patient had an significant calcification all over the vessels. You can see what we had done is we have opened the groin, done the endarterectomy, created an SFA ostia, made a patch. Through the patch, then distal popliteal was significantly calcified. We did IVL for this patient, intravascular lithotripsy. Post IVL, improved the compliance of the vessel, did a balloon plasty, and then placed a supera in this patient. So this is the placement of superior on the same patient, and this is the final run. So these are various combinations. So I would say it's a limitless arena where you can do multiple interventions. Thank you so much. If there are any questions at this stage, anything which you want to ask, I'll be more than happy to share with you.
Yeah. Thank you, Dr. Tarun, for a great talk. And I agree, if possible, if it can be treated, if there is no comorbidities, can be done in local anesthesia. We should treat whatever is required in one go, so that, especially in our geographical area, where patient saves a lot of financial burden is there. They travel from far off places to tertiary center. So I think that's need of the hour with the state of art hybrid OT. So last talk I'll be talking on proximal SFA osteal lesions, and I'll be talking on sugar technique. So let's do that. Okay. So this would be the last talk. I'll be talking on sugar technique. So the topic is learn the endovascular art of managing complex proximal and osteal superficial femoral artery lesions with novel stent design. And sugar implies to supera implantation with ultrasound guidance for superficial femoral artery osteal lesions by retrograde approach. So coming to what are complex SFA lesions. So basically, in a tertiary care center, whoever is working will realize that we hardly get focal short segment less than 5 or 15 centimeter lesions of SFA. Most of the cases which are referred in a tertiary care center have multiple lesions, as Dr. Grover has already discussed. So, for example, looking at this image, there is complete occlusion of SFA from the ostia with reformation at some distal level. Here you can see there is a short segment CTO with multifocal areas of stenosis involving the proximal SFA close to the ostia. So on and so forth. Here you can see bilateral SFA multifocal involvement with disease mainly pertaining to the proximal SFA and the osteal lesions. So these are just a few of the CT angiography reconstructed images. So in such lesions, when you're going with an endovascular approach, I'll be discussing on the need for basically the how important is to choose a right device for I would say not only long-term patency but mechanical failure should not happen, which is at least in our hand. So we all know that SFA is called as basically a stupid femoral artery, and there are reasons for that because till date there is no perfect device that can be placed endovascularly which does not have limitations. I would say because there are multiple biodynamic forces acting throughout the SFA. Pertaining to compression, torsion, flexion, extension, rotation, and this leads to basically device failure. So in this slide, you can see in standing position how SFA looks, and when you keep on walking, sitting, gardening, and then we have our Indian squatting position, you will realize how a stent would behave in this artery, and it's bound to fail mechanically. So here is another diagram which is showing how a self-expanding nitinol stent can fracture because of the multiple forces which I have described. So coming to vasculomimetic stent, this is a boon actually. I'm not talking about the long-term patency, but at least it prevents the mechanical failure. It's not a laser cut stent. It's basically interwoven wires, I would say. And that is what makes it fracture resistant. Till date, we have not seen a single fracture of the stent. Uh, and wherever possible in the SFA territory, our and obviously popliteal, our stent of choice till date or to date, I would say, is Supera. So, for example, what is the downside of laser cut stent? We all know. See, neointimal hyperplasia, instant restenosis, those are going to happen in any metal. But this is something which is annoying after your great efforts of opening an artery. If something like this happens, it's really disheartening, I would say. So this is a fracture of a self-expanding stent at two levels in the proximal SFA, and then definitely it can be fixed by vasculomimetic stents which were not available earlier, and then the artery can be recanalized. Another example, I would say, the common site of fracture is basically an adductor canal region where the distortional forces are very high. This is a mag view, another stent, self-expanding stent, and it has fractured like a candy wrap, and again reconstructed with a vasculomimetic stent. So this is how this stent is important, and this is our choice for at least SFA. Another word of caution is, like we all know, CFA is still considered to be a no stent zone, and there are multiple reasons for that. Because once CFA is stented, the future bypass becomes limitation. There is always a plaque shift if you balloon at CFA or to the profunda. If you jail a profunda, there is a high chance that it may get occluded, and profunda is definitely a life-saving vessel whenever SFA goes down. So we should respect the vessel. Few words about the Presto technique. This was a technique described, and what does that mean is basically it's a precise retrograde supera stenting for SFA osteal lesions. So what the authors did was they stented the proximal lesion with a retrograde approach from the SFA ostia using supera, so that they don't jail profunda and prevent landing of the supera into the CFA, because we all know whenever a superior stent is deployed antegradely and the distal most crown, I would say it's very hard to predict because it can elongate or foreshorten depending on how you have made your bed. And that is the reason the initial crowns can be placed where you want, but the distal or the last crown, it's very hard to predict. And still, after like 500 case deployment, I would say it's not easy to master that art. So I'll be talking on sugar technique, which is a modification of Presto technique. So what is the limitation of Presto technique? Why a sugar we thought would be helpful to the operators? Because in Presto we know that profunda has origins from different, I would say, projections. Sometimes it's pretty lateral, sometimes can be posterior, sometimes can be anterolateral. So there are variations in the origin of profunda. So while you are deploying your stent retrogradely, there may be a situation where you may not be able to open the ostia of the profunda to precisely land your superior stent and prevent jailing of the uh, profunda. Sometimes, even with the best view, we cannot separate it. Another thing is you need real magnification while deploying the proximal crowns of the supera, so that you don't miss again the unwanted zone. So with slight patient movement, again, like most of the patients will be doing in local anesthesia, again, roadmap becomes basically hazy. So that's how the limitation. So if a case is like this, I would say go ahead with your Presto technique. It's great. You just do a run with your roadmap or with your marker pen. You can go ahead and deploy it. But sometimes it's really, really difficult to separate profunda in an image like this. Sometimes even here you're not able to exactly make out where the profunda is originating from. So in sugar, what we did was it's a modified Presto technique where we used an added ultrasound guidance, which is always there in your basically a angio suite or a hybrid OT for your access. So all you have to do is just use it before the deployment of Supera. So just focus your probe on the CFA bifurcation and demonstrate the SFA profunda ostia. The added advantage is you have a Doppler. So you can always use your Doppler. So no radiation, no obliquities. All you need is an ultrasound. So operator is more confident now to accurately land the first crown of supera at the exact ostia. So your access could be anywhere. ATA, PTA, you can access basically higher ATA, you can access popliteal, you can access distal FFA. So basically what you're doing is a retrograde approach for precise landing of supera so that you prevent jilting of profunda or landing into CFA. Here it's well demonstrated as a posterior origin of the profunda femoris artery. You have well demonstrated it in longitudinal cross section, and then go ahead with your deployment. The beauty of the vasculomimetic stent is being there are like 6 pairs of nitinol wires interwoven. It's really bright and ecogenic, I would say, on grayscale. You can see the nose cone, you can see the deployment of the first few crowns very easily. You can pull it back slowly, so that you engage your SFA ostia. That can be nothing better than this. Even on fluoro, you have to really mag, and if patient moves, there is a difficulty here. Even if patient moves, that's fine. You're on ultrasound and real-time imaging. So you can put your Doppler and the crown and the struts are seen very nicely, ecogenically, and then you can really distend your crowns so that it well opposes your wall. So that's the deployment, I would say. Another case, so here you can see the profunda is well preserved, and the right here. So you can do a Doppler and make sure that you have not jailed in. So it's just a modification, I would say. Another case, and then an image of, so then you can do your rest of your deployment on fluoro. With a low dose fluoro, you can really collimate it and then slowly deploy the rest of the supera, whatever length is required. So that's how another case. So these are all complex SFA lesions involving the proximal and the ostial segment. So that's another case, I would say. So learning curve, I think most of the interventionists, whether it be a vascular surgeon, cardiologist, IR, are well versed with the Doppler, and everybody knows how to use it. It's just basically I would say a flat probe. So all you have to do is just keep on your groin, and should be aware of how the basically nose cone looks and how the first crown which comes out looks. So I think just one case is what is required, and that should be more than sufficient for a learning on ultrasound how to deploy supera. So just in a nutshell, try to save common femoral artery if you can, and prevent jailing of PFA. In complex SFA lesions involving ostia and proximal SFA, I would say our stent of choice is supera, and the reasons I have already highlighted, that the mechanical failure is at least less, and that if properly deployed, we have seen the patency is really good or better than any other nitinol stent. But you have to make your bed nice and deploy it in a proper fashion so that it expands well, and it takes these struts takes a good diamond shape. Anterior deployment, as I said, is tough because it's difficult to make sure where the last crown will stop. Presto is a great technique and can be used whenever possible, but in case whenever there is a difficulty to separate origin of the profunda, I would say just keep your ultrasound probe on the groin and start deploying these in our Indian Journal of Clinical Intervention Radiology, and is available as a free access or an open access. Thank you.
Thanks, sir. So, in the interest of time, if you allow me, I have one question to ask, and I'd request Dr. Gaurav Chauhan also to be a part of this question and your expert views, please. So, how important is it to use filter device during a carotid artery stenting procedure? And what's your view on the use of filter device even for the lower extremities infections?
Hi Nidhi. So for carotid artery stenting, we usually, in almost all the cases, we always use a distal protection embolic protection device, because there are many studies which have mentioned that before the introduction of distal embolic protection device, the outcome of carotid artery stenting via endovascular technique were not great. But after the introduction of embolic protection device, if it is placed correctly, the outcome is quite great. So we usually don't give any kind of anesthesia. We just have our anesthetist as a backup for carotid artery stenting, just in case the patient have bradycardia during the procedure. So the outcomes are great with embolic protection device for carotid artery for sure. We don't have any quite a big experience for using EPD in the peripheral arteries. So we are not using it here in Medanta, Lucknow. But yes, for carotid artery, we are always using it. For one of few cases when we have not used it for obvious reasons, just like one case we have showcased today. So because the landing zone was not adequate for the filter to get opened adequately. So the landing zone was very small. It may lead to dissection if we have parked our EPD there. So that's why we decided to discuss it with family and neurologist. So that was a just calculation of risk benefit ratio for that patient. But yes, for carotid we always use it. For peripheral we don't have a experience to share with you.
Great. So thank you so much, sir, for the response. And probably in the interest of time, I would like to conclude the session by thanking our expert panelists for joining us today and sharing their viewpoints on the peripheral artery diseases and its management. Also, thanks to the presenters, Dr. Abhishek and Dr. Gaurav. We will be back with another session of Bright Talks soon. And till that time, we wish everyone to stay safe and wish everybody a great weekend.
Thank you, Nidhi.
Thank you, sir.
Thank you so much, sir.
Thank you, sir. Thank you, sir. Thank you,
Thank you
Nidhi.
so much, sir. Thank you.
Thank you. Thank you.